Hello, and welcome to the final day of Long COVID Families Back to School Conference, Day 4. Yesterday, we explored how to prevent illness. Today, we will discuss advocacy. We have two presentations this morning that will set the groundwork for our advocacy conversation. In our first presentation, Dr. Jeoffrey Gordon explains what public health has to do with COVID and our schools. Then Dr. Sarah Steinbacher introduces a concept that may be new to some of us: adultism and how adultism informs our public health response. This afternoon, we'll focus on advocacy, and we'll include a presentation about the National Institute of Health's Recover Initiative, which aims to study the long-term effects of COVID. Again, thanks for being here.
Dr. Jeoffrey Gordon is a medical doctor and advocate with the People's CDC. He's an advocate for civic and social justice, experienced in palliative care, medical bioethics, child abuse prevention, psychiatry, COVID-19 epi management, and clinic management. Today, he's going to be speaking to us about the role of public health.
Hello, my name is Jeoffrey Gordon. I'm a family physician working with the People's CDC. Today, we're going to talk about the relationship between public health and COVID safety in schools. Objectives that I will cover include explaining the term public health, explaining examples of effective public health practice throughout history, identifying 3 ways public health can impact COVID spread, and explaining how public health measures will help minimize the impact of COVID in schools. In our culture, by and large, we all generally privately assume direct responsibility for our personal and family health, safety, and security. But there are many circumstances when we depend on resources developed and provided by the community, such as police, fire departments, lighthouses, interstate highways, the internet, schools, and sanitation. These are called technically public goods. They are resources to deal with problems and challenges that no individual can or should have to deal with alone, that are often impossible or too expensive for an individual to finance, and to look at needs and risks broadly, protecting the whole community, to gather resources collectively, to use them systemically and systematically to prevent adverse consequences or produce benefits. It should be noted that commercial enterprises are not good at creating public goods. Government-led public health policies are one of the major reasons that we can enjoy clean air, safe foods, less harm from pesticides, improved dental health, and freedom from transmissible diseases. Public health is a public good. As we shall see, the public health approach is far more capable, indeed necessary, to manage the problems from COVID in schools. One good example of the benefits of a public health approach is drinking water, which throughout the USA is purified by a local government agency for everyone. Thus, without thinking about it, we can dependably drink water straight from the tap, without any worries. When public health is overlooked, as it was in Flint, Michigan, considerable harm can follow. Another example is waste management. In most areas, we flush the toilet and the water just goes away, in reality, to a governmental agency for purification and disposal. This system is designed more to minimize the spread of disease than for aesthetic reasons. Of course, in rural areas, isolated people have to use septic tanks, which they must privately maintain. In fact, modern epidemiology and public health started in London in 1849, when investigations by Dr. John Snow determined that drinking water coming from the communal Broad Street pump was contaminated by sewage from the Thames River, causing a year-long cholera epidemic with many fatalities. He solved the problem, stopped the epidemic, by removing the pump from the water fountain. It is important to recognize that when we use systemic surveillance to prevent harm over time, public health benefits become invisible. Thus, using personal, ordinary thought, experience, and intuition, it is hard to contemplate public health benefits. Public health investments, unlike fire engines, parks, schools, or stadiums, are more concrete than public officials can easily brag about. Thus, public health may be systemically under-resourced until there is a breakdown or an emergency, even though the return on investment in public health may be 300 to 500% or more. The trouble is that in public health, the actual energy, actions, and dollars are spent now and are specific, tangible, and burdensome, while the returns happen in the future and are often in the form of problems that do not happen. Foregone illness, deaths, disability, and loss of productivity are abstractions, are not on anybody's budget, and are generally overlooked as we go about life without problems. Vaccines are one of the biggest successes in public health, but due to a number of reasons, nowadays people hesitate to take the new ones like the COVID-19 vaccine, even in the face of strong evidence. Take the case of vaccinations to protect against COVID-19. Public health science and practical wisdom recommends their use. For many reasons, substantial numbers of people have avoided vaccination. This may be for personal reasons, such as fear of side effects or unknown consequences, not wanting to take time off from work to get the vaccinations, distrust of authorities, or for religious or political values. But COVID has gone on so long that we can now calculate the return on our collective investment in vaccines. Data shows that in the United States, quote, COVID vaccination was estimated to prevent 27 million COVID infections, 1.6 million COVID-associated hospitalizations, and 235,000 COVID-associated deaths among vaccinated persons 18 years or older from December 1st, 2020 to September 30th, 2021. By that date, September 30th, 2021, vaccination had prevented an estimated 52% of all expected infections, 56% of all expected hospitalizations, and 58% of all expected deaths. Public health also looks at systemic factors that can inhibit a person's ability to access or maintain health. These are called the social determinants of health, which can include where you live, your income, your housing situation, your ethnicity, the history of racism or discrimination in your community, and other factors. For example, Black women die in childbirth at 4 times the rate of white women due to a number of these systemic factors that are beyond their personal control or beyond the control of any individual obstetrician, but they can be addressed by widespread systemic public health and medical interventions. Public health initiatives have successfully addressed some environmental factors that affect health, like air pollution, lead paint, asbestos, and we are now trying to do the same with social factors. A lot is known about applying the public health framework to COVID and schools because historically schools have had to deal with tuberculosis. Tuberculosis is a deadly bacteria that, like COVID, is also spread by an aerosol from an asymptomatic person. This germ has historically caused school and workplace outbreaks, so that now all teachers have to be tested for tuberculosis each year. At the start, when we knew nothing about COVID, everybody was at serious risk. It was uncertain how the germ was passed, and many people, even young, healthy, vigorous people, were dying horrible, tragic deaths. Under these circumstances, it was necessary to close everything down to minimize interpersonal contact. The school population, including pupils, teachers, and support staff, was essentially a cross-section of the whole community. From a public health perspective, schools are a very high-risk environment because a lot of people interact in a closed space for a good period of time. In these circumstances, leaving preventive measures to individual choice will certainly fail. The public health view also encompasses the reality that young, relatively resilient pupils, teachers, and staff who may be able to avoid serious illness themselves can carry COVID home to families, threatening high-risk individuals there, such as pregnant moms, grandparents, and chronically ill relatives. In retrospect, we can probably all now agree that it was unnecessary and harmful to keep the schools closed for as long as we did. And now we can use different approaches. In this infectious situation, as we see it now, if it were left up to individuals or families to decide how to deal with the germ going around, we could see that we would have a very leaky system, as some people would choose not to be bothered and could spread the germ, especially since about 40% of the cases of COVID are asymptomatic. Now that we know so much more about COVID, there is no doubt that with systemic public health principles, it is unlikely the schools will ever have to be shut down again. The secret is to apply preventive measures to everyone and to build layers of protection. Not only will this protect each student, teacher, and staff, but it will also protect surrounding family and communities and keep the schools open. No doubt cases of infection will continue to occur, but classes can be held with little worry about an explosive outbreak. I'm now going to list the important systemic public health measures which are highly recommended. Number one, everybody should be completely vaccinated, including all recommended boosters. Number two, everyone should wear an N95 or KN95 or equivalent mask all the time. Number three, all classrooms should have proven good ventilation, with the windows open when possible. Eating is best done outside if possible. Number four, anyone who is sick in any way should stay home, since COVID can have a great panoply of symptoms. Anyone who does have proven COVID should isolate at home for 10 days. 5, as much as possible, all classes should be kept bubbled and not intermingled. So if there are infections in one class, the risk to the other classes is minimized. Number 6, rapid antigen testing should be available, at least to be used on an as-needed basis in the school. Maximum protection is obtained by surveillance testing of everyone once or twice a week, as long as there is significant community spread. Maximum protection involves quarantining at home for 10 days anyone exposed to an active COVID case, so some distant learning capacity is needed for each school. 8, taking temperatures, frequent hand washing, and pupil separation by 6 feet are all not necessary if the other precautions are used. And number 9, mitigation procedures can generally be phased out when community case rates fall below 15 cases per 100,000 residents per day. Using these systemic, well-known, proven effective, protective public health layers of protection, everybody's safety is maximized, and schools can continue to function. School administration must supply the masks, the tests, the HEPA filters free in the same manner that they supply heat, light, and water. These measures are more effective the more people use them, and thus are most effective when they are mandatory. This is not a matter of limiting one's freedom of choice, but of wisely taking personal action to protect yourself, your friends, your family, and your school. Already, some businesses have had to limit operations due to personnel shortages due to acute disease and quarantining. This can happen to schools as well. In addition to considerations of the spread of infection, prolonged disability of students, teachers, and staff due to long COVID can really impair the educational experience. Nobody wants to see schools shuttered again, and success requires everybody's cooperation. Thank you.
Dr. Sarah Steinbacher is an early childhood education leader and curriculum writer. She is also a volunteer with Long COVID Families. She served over 20 years in the early childhood education industry and focused on curriculum development, teaching adult learners, educational technology, program management, and professional development. Today, Sarah will be speaking to us about adultism.
Hello, welcome to this session on adultism and its influence on public health. I'm your host, Dr. Sarah Steinbacher. I have a doctorate in education and over 20 years of experience as an educator, curriculum writer, and trainer. I'm also a volunteer advocate with Long COVID Families. I'll be covering 3 basic questions today. What is adultism? What does it have to do with public health? And what can we do instead? For the purpose of this session, when I discuss adultism's impact upon public health, I will be using our COVID-19 pandemic response as an example. The pandemic has made one thing abundantly clear. Even though we are all going through this same storm, we are weathering it in very different boats. Racism, classism, sexism, and ableism have all shaped our pandemic response to impact some communities harder than others. Thankfully, many people have been sounding the alarm about these important issues. Unfortunately, there's another system influencing our pandemic response that hasn't gotten any widespread attention because most Americans still consider it socially acceptable. And that hidden system is adultism. Most people have never heard of adultism, even though their lives have been significantly affected by it. So what exactly is adultism anyway? That's what we'll cover in this first section. Dr. Barry Checkaway described adultism as all of the behaviors and attitudes that flow from the assumption that adults are better than young people and are entitled to act upon young people in many ways without their agreement. While most of us would never come out and say we think we're better than children, many of our interactions with them point to the underlying assumption that pretty much amounts to the same thing. When you think about it, outside of people who live in prisons or institutions, children live some of the most closely controlled lives. Adults control young people's actions, denying them the personal agency to decide what they want to do or not do and where they want to go. Adults rule over children's bodies, denying them body autonomy to decide if they want to eat particular foods or if they feel comfortable hugging a certain person or not. Adults also reserve the right to punish children for behaviors or emotions they disapprove of. Children aren't allowed to have a bad day in the way that adults are. When a child says something snarky to a parent, they might be accused of talking back and have their cell phone taken away. But that parent wouldn't treat a partner, coworker, or friend the same way for saying something snarky. The difference is, because of adultism, adults feel they are owed a greater degree of deference and respect from children that they don't feel they are owed from other adults. This is especially out of sync with child development and brain research, which tells us that children are still learning social cues and impulse control. So why are we so hung up on this? In part, it is because we feel pressured for our children to behave according to societal norms. We see them as a reflection of ourselves. Young people are not seen as separate, unique individuals deserving of personal agency and autonomy. Instead, we view children as possessions that parents or teachers can decide how to handle. We center our needs over our children's and deny them the ability to advocate for themselves, because when they do self-advocate, we call it talking back. And adultism is not just found at home. It's in our schools and laws too. In a given school day, children are told who they could sit by, when they can talk, what they can wear, and even when they are allowed to eat or go to the bathroom. But that's not even the worst of it. Believe it or not, corporal punishment in schools is still legal in 19 states, even though the physical assault of adults is illegal in all 50 states. Corporal punishment is still permitted precisely because children are seen as property that adults can treat however they wish. Adultism assumes young people need harsh, authoritarian treatment to be able to develop properly. To be honest, formalized schooling, for all the good things it does, is still motivated by capitalist adultism. Selma James said, "Schools are institutions organized by capital to achieve its purpose through and against the child." What she means here is that schools serve two primary functions. First, they essentially babysit children so that workers are free to work. Second, they are simultaneously preparing future workers to enter the workforce. Capitalism depends on both of these adultist aspects of formalized schooling. This is especially relevant to our discussion on our pandemic response, as you'll see in a few minutes. This idea of adultism may be a radically new concept for you. Right now, you may be asking yourself, how have I never seen this before? Well, you're not alone. As a society, we don't acknowledge adultism. Imagine I told you I had a friend whose spouse controlled what she ate, wore, said, and did, and if she ever disobeyed him, he would physically hurt her. I'm sure you'd have no problem labeling his behavior as abusive. Yet when children are treated in the very same way, we don't label it as oppressive. Why is that? There are two big reasons we have a hard time seeing adultism. First, adultism is all around us. We see it in the movies and shows we watch, the news we follow, and even many of the parenting books we read. So we're socialized to think it's normal. Second, it's how we ourselves were raised. That's caused us to internalize many of those adultist beliefs. For example, many parents try to justify corporal punishment by sharing their own experiences of childhood spanking. We often want to justify our own parents' adultist actions because we care about them, and we don't want to have to acknowledge the ways in which they may have harmed us. But research has shown that spanking harms children's brains in similar ways to other forms of violent abuse. It doesn't help children to deny these truths because facing the adultism in society and in ourselves is uncomfortable. Now that we have a basic grasp on what adultism is, let's turn our discussion to how it impacts public health. UNICEF has stated that in this pandemic, children are often silent victims without a voice or platform and are among the most vulnerable. But has anyone stopped to ask what makes children silent victims? What denies children a voice or platform? What causes them to be more vulnerable? The answer to all of these questions is simple: adultism. In this section, I'll share 6 ways that adultism has shaped our pandemic response and harmed children. First, throughout the pandemic, there has been a steady stream of disinformation shared about how the pandemic affects children. Disinformation campaigns have inaccurately stated that children don't get COVID, or if they do, they don't really get that sick. Who can forget this tweet from Elon Musk in which he said children were essentially immune? This messaging is both false and harmful. Research has shown that over 75% of children have already had COVID at least once, and about 1 in 16 develop long COVID. So children do get sick, and it can be serious. Disinformation like this prevents parents from being able to coordinate care for their children. According to the People's CDC, it also leads to the underdiagnosis of COVID and long COVID in children. It creates barriers to COVID treatments and school accommodations, and it results in fewer COVID mitigation strategies in schools. Over 60% of the country thinks the U.S. has not prioritized K-12 students enough to meet their needs since COVID started. In this tweet, Becky calls the CDC's failure to attend to the needs of children during the pandemic as the greatest example of adultism she's seen in her lifetime. The second way our pandemic responses have been adultist is in the way COVID research, resources, and agencies have centered adults. There have been relatively few COVID studies even conducted on children, and the ones that have been done are often based on flawed assumptions. This only further contributes to the pediatric COVID disinformation problem. What's worse, our tests and treatments were designed for adults. We've only just now discovered how unreliable rapid tests are at correctly identifying COVID in children. Parents can't really give informed consent for the level of COVID precautions they feel comfortable with because the lack of research and reliable testing prevents parents from having an accurate understanding of children's risks. Then there's the issue with the many needless delays for children's vaccines. Parents with children under 5 have said they felt forgotten in this pandemic because our public health system failed to appropriately prioritize young children. As I shared earlier, capitalism depends on schools supervising children so workers can work. Whether it was explicitly stated or not, school reopenings have always been about economic priorities and not educational or public health ones. Even at the height of the Omicron surge, the majority of school districts maintained in-person classes, and very few even bothered to adjust their mask policy. You'd think school districts would try to learn from their prior mistakes, but the districts hardest hit last year have already said they are not planning any significant adjustments to their COVID protocols this year. As of the date of this recording, the CDC is expected any day now to ease their school recommendations even further based on shifting public sentiment about masking and what amounts to disinformation about COVID immunity. Although over 75% of children have already had COVID at least once, research has shown that COVID antibodies wane over time and aren't as effective as vaccine antibodies. However, only 30% of children aged 5 to 11 have been fully vaccinated from the virus, and that doesn't even take into account boosters. It seems as though school districts and public health agencies have given up on protecting children from getting COVID or long COVID while attending school. One district official said the quiet part out loud when he declared that COVID outbreaks in schools were acceptable as long as parents don't, quote, miss their shift job. But this capitalist adultism is only a short-term gain for many long-term losses. When COVID is permitted to spread unchecked in schools, it leads to overall community transmission and therefore worker shortages. For example, just looking at teachers alone, we've seen how outbreaks among students have led to large-scale teacher staffing issues and chaotic school environments. And that's likely to impact schools for years to come, as 1 in 5 teachers now have long COVID. It's time we realize that what is good for children is also good for families, schools, communities, and the economy. The fourth way our pandemic response has been adultist is COVID politicization. Both the previous and current administrations have significantly politicized their pandemic responses. State and media outlets have strategically disseminated information to compel people to believe certain things and essentially manufacture their consent. This propaganda can be benign. For example, masking and vaccine campaigns can encourage people to hashtag mask up, vax up. But on the flip side, anti-vax and anti-mask propaganda spreads disinformation to manufacture consent against vaccines and masks. Manufactured consent has been around for decades, but thanks to social media, many people now actively participate in manufactured dissent, whether they realize it or not. Manufactured dissent is when members of the public participate in spreading disinformation and propaganda, and it's been everywhere, from vaccines to hydrochloroquine to ivermectin to the myth that children do not experience serious symptoms from COVID-19. Countless politicians have used children as pawns in their political games. Unfortunately, the decisions they have made have had significant consequences for the health and education of millions of children. Politicians have blocked education funding and threatened districts that try to implement COVID precautions. It's gotten so bad that the U.S. Education Secretary has censured several politicians for their actions. Politicians need to stop gambling with children's lives. This politicization is especially problematic because young people are denied the agency and suffrage to be able to vote out the politicians that rule against their interests. The fifth adultist aspect of our pandemic response is the urgency of normal movement. You may or may not have heard of it. Recently, a group of physicians and scientists have begun to call for an end to all COVID precautions in schools. Their rationale is based on disinformation about pediatric COVID cases. The group encourages people to make individual risk assessments, but that's not how public health works. They argue that COVID mitigation measures cause children emotional strain. People have used disinformation about this to try to end precautions that they don't like. These disinformation campaigns are effective because children's mental health is indeed a problem. But the research is clear on this. Masks do not harm children's mental health. You know what can cause mental health issues? Getting COVID or losing a loved one to COVID. Even before the pandemic started, we were already in the middle of a pediatric mental health crisis. Most people just didn't see it because of adultism. The pandemic has helped shine a spotlight on this important issue, but it didn't cause it. Many other doctors and scientists have come out against the urgency of normal movement. One of the chief criticisms is that the push for normalcy through no precautions centers the least impacted communities. They fail to consider how marginalized communities experience barriers to vaccination and treatment. As Leslie tweeted, all kids have the rights to safe schools, not just the privileged ones. The final way our pandemic response has been adultist, or at least the final way that I'll cover today, is how children have been denied basic rights and agency granted to adults. This really gets to the ways in which children are an oppressed class. They are denied autonomy and voting rights, they are held to higher standards of emotion regulation, and are subjected to corporal punishment. But this is also shown up in how children experience health care. Children cannot legally give consent for their own medical care in most states. That includes the ability to consent for a COVID vaccine if their parents refuse to do so on their behalf. Young people also face barriers in independently accessing their own health care due to transportation restraints and copay costs. In most places, children have little to no control over the safety precautions of the environments they inhabit because the adults in those spaces set the rules. For example, a 14-year-old who wants to mask at school is dependent on finding an outside source for their masks if their parents refuse to provide them. But today's youth are becoming more and more aware of their own oppression. Over the past year, students in cities like New York, Chicago, Boston, Seattle, Austin, Detroit, and Oakland walked out to protest insufficient COVID precautions in their schools. Unfortunately, many of them were dismissed by legislators and COVID minimizers as paid actors, or worse, just a bunch of kids. Because of capitalist adultism, we mandate children's school attendance, but because of pandemic adultism, we have failed to provide a safe learning environment for them. So we make them go, but we don't provide for their safety. And to top it all off, we deny young children the ability to change their circumstances and often pathologize their self-advocacy as mental illness or teenage angst. Students that have protested have faced unexcused absences and even disciplinary action, just for speaking up for their own health needs. Adultism denies young people that right. Whew. That was a lot, right? You may be thinking, how the heck can we even begin to chip away at all of that? Okay, let's all take a collective breath. Breathe in. Breathe out. Whenever I start to feel overwhelmed, I find that pausing to take a deep breath really helps. Now, adultism is a beast of a system, but it is a system, which means it was built and it can be unbuilt. In this last section, I'll cover some basic steps we can all do to disrupt adultism around us, so collectively we can start to see this system dismantled. Before we seek to tackle the adultism in others, we must first address the internalized adultism we all have within ourselves. It starts by seeing children as full persons deserving of the same respect and rights as adults. A helpful self-assessment is to ask yourself some of the following questions. Would I say or do this to an adult? How would I handle this if it was with my best friend instead of a child? How would I want someone to respond to me in this situation? Reflecting on these types of questions can give you the reframing you need to proceed in an anti-adultist way. And if we answer these questions honestly, then we have to address corporal punishment. Activist bell hooks urged adults to divest from familial power dynamics, including corporal punishment. That can be challenging for caregivers who have only known harsh authoritarian styles of parenting. Nonviolent caregiving doesn't necessarily mean permissive parenting. Healthy parenting should involve boundaries and mutual respect. It's out of the scope of this presentation, but for those interested in learning more about alternatives to corporal punishment, I encourage you to research nonviolent caregiving methods like gentle parenting or conscious parenting. Divesting from adultism also means that we need to stop prioritizing our own adult needs over children's needs. Children deserve safe learning environments. That needs to be a priority. And if that means mask mandates or virtual learning during surges, then we need to commit to doing what's best for them, not what's best for us. This one may sound super basic, but it's actually quite revolutionary. We should believe children. Adultism would have us assume children are lying or trying to manipulate us. But anti-adultism defaults to believing children are good and trustworthy. This has many implications for the pandemic. As inconvenient as it might be at 7 a.m. on a Monday morning, if our child tells us they have a headache or stomach ache, we should believe them and trust them to know their bodies best. It might be tempting to shrug it off and tell them they'll be okay and get to school, but the reality is their symptoms could be an indication of COVID or long COVID. Instead of dismissing them because it's more convenient to ignore their symptoms, we should respond with curiosity. Ask open-ended questions to encourage your child to describe how they feel and how long they've been feeling that way. Showing curiosity validates your child and communicates to them that you care about how they feel, making them more likely to tell you things in the future. Plus, it helps you catch important symptoms at an earlier stage. Another important part of anti-adultism is empowering young people. We need to let them know they have the right to set boundaries of what they are comfortable with and what they are not comfortable with. Of course, that means we have to honor the boundaries they make. If your child says they don't feel safe somewhere, instead of pressuring them to push through, again respond with curiosity. Ask them what causes them to feel unsafe there and what might help them feel safer. And that way you validate their concerns and can work on making the necessary accommodations to address those concerns. When you do that, you are communicating to your child that you value their feelings of safety. Related to this, we should support children's body autonomy and personal agency. In other words, we should allow children to have input about what happens to their body and their life. It's easiest to start practicing this at home. You can then begin to role play with children how they can self-advocate in other situations, like at school, sports teams, clubs, or church. It's helpful to practice this with children so they feel more prepared. Speaking up to adults can be an intimidating experience for some children, but the more practice they have, the more confident they are likely to feel in the moment. Talking through situations ahead of time also helps. For example, if your child is planning to go over to a friend's house, you can talk through potential scenarios. You could say something like, I know you're looking forward to hanging out with Sean tomorrow. It's great to hear he masks at school just like you do. Sometimes people have different rules at home than they do at school. I know you've said you feel more comfortable with a mask on around people outside of our family right now. What do you think you might do if you get over to Sean's house and they don't mask at home around others? Do you want to practice what you could say? There are many things we can do to help dismantle adultism in institutions like school districts and public health organizations. For one, we can push back against the urgency of normal movement, both locally and nationally. Pandemic precautions don't have to be all or nothing like the urgency of normal crowd imagines. Gretchen Kelly, a disability advocate from long COVID families, has said, no one wants an endless future of masking. No one is suggesting we live in a dystopian gray expanse of isolation and lockdowns. The insinuation and suggestion that disabled people want that is propaganda, aimed at painting our community as holding everyone back. It's manufacturing consent to disregard us and dispose of us. We can push back this narrative, most parents support reasonable and equitable COVID precautions. To help with this effort, grassroots organizations and public health experts created the Urgency of Equity movement as a response to the urgency of normal group. They prepared a toolkit that you can download now and share with your local school district. It includes research and the best practice recommendations for prioritizing the collective health of all students. Young people become naturally more and more involved in advocacy as they mature. We should support student activism in our schools. We should also speak to principals and district leaders about implementing avenues to incorporate student feedback. We can advocate for children's civil and political rights, making sure to include young people in our organizations as we do so. When you are looking for a place to contribute, vet the organization first to see if they practice anti-adultism. For example, Long COVID Families is the only long COVID nonprofit organization in the U.S. that specifically centers children in their advocacy work. And when you look deeper into their culture, it intentionally aligns with an anti-adultist approach. Megan Carmelani, founder and principal of Long COVID Families, has said children have been left out of the equation in regards to COVID safety. They don't have the agency to calculate personal risk tolerance. Therefore, the responsibility falls upon adults to center the needs of our kids. We shouldn't gamble with their health simply because it's convenient for us. Many children experience long-term debilitating complications from COVID. As adults, we can and should do something to prevent that from happening. The health of our children is worthy of protection. When we engage in advocacy work, we should be looking for organizations like this. As I've shown today, adultism significantly endangers children's health. But it's also worth noting that it perpetuates other systems of oppression as well. When children grow up experiencing adultism, they learn how to operate within a hierarchical system. They accept that system and wait for the time when they're old enough to reap the benefits of it. But then as adults, they repeat the cycle of harm to younger generations. And when people accept one hierarchical system, it can reinforce other hierarchical systems like racism, sexism, classism, and ableism. But on the other hand, when we work to dismantle adultism, it destabilizes all hierarchical systems. And that way, engaging in anti-adultist advocacy can make ripples of change for years to come. Not only will we be fighting to protect children's health, but we will be fighting intersecting systems of oppression as well. Thank you for attending. If you have questions about this presentation or adultism in general, please feel free to reach out to me at the email address on the screen, sarahsteinbacher24@gmail.com. That's SarahSteinbacher24@gmail.com. Thank you.
Kristin Urquiza is a disaster equity advocate and co-founder of Marked by COVID. She earned her BA from Yale and NPA from UC Berkeley's Goldman School of Public Policy. She co-founded Marked by COVID after the death of her father to COVID-19. Marked by COVID is a national grassroots, nonpartisan nonprofit that promotes accountability, recognition, justice, and a pandemic-free future. Today, Kristin's going to be speaking to you about equity in schools.
Thank you so much to Long COVID Families, to your leadership in pulling this incredible conference together over the course of the last few days to ensure that folks have the tools that they need to have really important conversations about keeping ourselves, our children, our families, and our communities safe as we enter into this next school year of uncertainty. And for my conversation today, I am going to talk a little bit about equity, in particular, equity as it applies to schools. And I just wanted to take a couple of steps back before I jump in and build upon my biography, which was shared there, and just share with you all the entire reason why I've been doing the work that I'm doing is because of my lived experience through this pandemic. Early on, my dad got sick and he passed on June 30th, 2020. And prior to my dad coming down with COVID, I had taken time away from my career and had gone back to graduate school for a mid-career program at UC Berkeley to get a master's degree in public policy, focus on how do you make equitable policy. This issue of equity has really been sort of at the core of my concern for most of my life. And I think that the language that we have now has developed really quickly over the course of the last 5-10 years. The context of the pandemic has been something that many of us have been talking about, but I'm not sure the general sort of understanding of what equity really is. So I want to take a couple of moments just to kind of dive in on that front and then talk about how it applies to its schools. But the other piece I just mentioned was that my lived experience and my dad's own story with COVID. So I graduated from grad school at my mid-career program in May of 2020. So a really interesting time to be in school. And it was less than a month later that my dad got sick. He lived in Arizona, which is where I grew up. I now live in San Francisco. I had a really clear memory of the city of San Francisco, the county, and the Bay Area very boldly and very early on declaring a state of emergency to loosen up resources. And I was driving over the Bay Bridge. And for folks who were in the audience that know the Bay Bridge, it's always an adventure to go from one side to the other. And I just remember saying yes really loudly in my car. And I said that because I knew it would start giving the city, the county, and the area surrounding us the tools that we needed to be proactive in case the worst thing happened. And as we all know, the worst things started to happen, and I had a front row seat to sort of the model public health, equitable public health response, and then a front row seat with my parents in Arizona to everything that you shouldn't be doing. And that that resulted in a personal nightmare where, as the state of Arizona reopened in May of 2020, there was a push to get people back out into the economy, buying things. There was a push to declare a victory on the pandemic. And folks like my dad, not being super close to the issues, but generally following sort of the news of the day, got sick. And the really tragic thing from an equity perspective was that my neighborhood was not only the worst place in Arizona, when Arizona was the worst place in the country for COVID transmissions, it was the worst place in the world. Now, this is a, very large working class neighborhood that's, been around for 60 years. As the community I grew up in Maryville, was actually the very first subdivision created right after World War II to help bring in sort of modest, but, like homes for working class families coming back from the war to be able to start a life. It wasn't in a rural place, it was in the middle of a city. And here in the US, we had some of the worst cases and transmission early on in my childhood neighborhood, which happened to be at this point in time, 80% Latino and 40% immigrant. Folks were waiting in line for 14 hours in 115-degree weather for a COVID test, whereas folks on the other side of town who had access to cars, didn't rely on public transportation, were able kind of to walk up to clinics to get serviced right away. And so this idea of equity and who suffers first, who suffers continuously, and once all of our attention sort of, goes away from the problem, who will continue to you have to deal with the problem, was very forefront in my mind. Had we had an equitable response in Arizona, we would have had, testing in all of the grocery stores, in all the, bodega type grocery stores in my very working class community. The city would have been thinking about policy that would have enabled those folks to have paid time off without being at a disadvantage of potentially losing their jobs, so on and so forth. And so this is where we now pivot to what is equity in schools. It's the same type of framework that we're thinking about, and that equity really starts from this position of thinking about how do we change the landscape through policy and through changing hearts and minds to be able to make it so that all folks have the opportunity to thrive. And so this is going to look different whenever we are applying it to, say, a workplace, or applying it to a school, or applying it within your community. But overall, the kind of idea is the same, with the goal being we want to be able to deliver high quality, safe education to everybody. And the idea of starting from the folks who need a little bit more sort of, how do we change the landscape to make sure that nobody is left behind, is sort of the core sort of kernel of thought behind equity as a concept, and then equity, more generally as a school piece. I'm going to share a couple of images with folks that might be familiar. This is often an image in which has been used over the course of the last 10 or 15 years to describe equity, where you have these children looking over a fence to a ball game. And in the first box, the first kind of picture on the left, you see 3 boxes that are equal that each person has, and the person on the left, the shortest person, still can't see over the fence. The image on the right has commonly been used as a model for equity. And I think this does a good job in describing the difference between equity and equality, which is often kind of mixed up in just our common everyday speech, in which in the idea of equity, it's not one for one. It's about kind of changing the landscape to make sure everyone is brought up to a way in which they can participate. But some of the challenges with this image are rooted in ideas of white supremacy, in which the person who's short to begin with has some sort of deficit. And so I actually turn more to this tree image of what is equity and equality, thinking about this idea of justice down in the end, where you're really looking to fix the entire system to offer equal access to both the tools and the opportunity. So this image, I think, does a much better job of really kind of getting at that next level of systemic changes, and systemic changes that can be made in the context of schools. And so here you have, I think this is like the image from The Giving Tree, which is a really sad book, if you ask me. But here you have on the left-hand side inequality, in which the one child has an abundance of apples, being able to kind of have them just falling at their lap. Equality is giving the 2 children the same exact ladder, but you're still seeing the child on the right where the tree is leaning the other way. There are less apples there. So equality is not quite adding up. Equity, you have this concept of helping to bring both of the children up to be able to reach the apples. But in this concept of equity towards justice, you've actually been able to fix the leaning of the tree. There's a more equal distribution of apples in the right place, and both children are able to pick from the tree and be able to kind of go throughout life. So that sort of crash course in equity brings us back to the topic of hand of equity in schools. And I'm just going to breathe here for a minute, because I know this is a hard concept, or it's not a hard concept. It's a volatile topic, in that we have gotten as a society so far away from our values that we are seeing things in this really terrible political divisive nature. When folks are talking about equity in schools, they want to make sure we are wanting to make sure that every child, every teacher, every custodian and other staff and administration can work, learn, play, and grow in a safe learning environment. And right now, we are living still through a pandemic that is airborne, and a pandemic that, while we have made incredible technological advances with the advent of vaccines and boosters, in more than one mitigation approach in order to make sure that schools are accessible and safe to all children. And so these, luckily, these mitigation measures we have at our fingertips. We know that high quality, well-fitted masks, such as a N95, a KN95, and others, when universally applied, greatly reduce the transmission of the virus. We also, from person to person, we know that ventilation is another underutilized tool that actually changes that whole infrastructure. So thinking back to that tree where we're like pushing it back over, more evenly distributing the apples, ventilation and upgrades to ventilation systems is a really underutilized and incredibly effective tool in helping to combat the transmission of COVID. And unfortunately, ventilation in many of our schools, in particular public schools, older public school buildings, probably have not been updated since they were built. That means that they don't have the high quality HEPA filters. They're not screening for airborne particles. And this has incredible impacts, not just on COVID, but for a whole set of other respiratory diseases that happen naturally over the course of the school year. This can make a huge difference in bringing down days lost from school, just from colds and flus, as we see, which to me is benefit enough. But this also helps make the learning environment a lot safer and accessible to all children. Share some that I've been doing, but I've been reading recently about the air quality the quality of air in and of itself, fresh air, recirculated air, the amount of pollutions in indoor air, COVID aside, the cleaner the air is, the more positive the results on a child's ability to learn. So not only is ventilation a win-win and an equitable win, it's also a way in which to squeeze more learning juice, into sort of the environment of schools as is. And then other mitigations measures also can be employed to help specifically get to COVID, but to really tackle COVID. But I think from an equity standpoint, a couple of things that we can just do right away to help keep folks safe, be able to keep people learning, is to have those ventilation options. Short term, you can get people into masks. Long term, working together with the school district, the school board, other parents to get ventilation upgrades. And then something that I just came in to hear a moment ago is there's still going to be some folks who, with those considerations, it is still not safe for them to be in the classroom. And so whether it's hybrid options, other types of options, to figure out how are we still providing and delivering on not only our promise, but our legal promise to provide education for all sorts of children, all people, is an important conversation for us to be having to ensure that we are not leaving anybody behind. And I want to make sure that there's, time for questions, but I also want to recognize the context of what so many families, teachers, medical professionals, academics have been probably feeling. It can feel like we are losing. And I think that there have been many instances in which our politicians, irrespective of party, irrespective of position, have failed us. But the places in which I have seen incredible things happen actually is whenever a small group of dedicated people come together with a common goal and push on that common goal to make change happen. I was on a call last night I hosted with our community, which is people who've lost loved ones from COVID, who are living with long COVID. A lot of people in the immunocompromised community who getting a COVID infection could be life-threatening for them. And we had a special guest on the last night, Dr. Opal Lee, who is commonly known as the grandmother of Juneteenth. Whenever she was 85, she decided that she wanted to make sure this became a holiday before she left us on this particular spiritual plane. And she's 95 now. And one of her core messages, if you need to be a committee of one, you be a committee of one. I am a little old lady with a good pair of sneakers that doesn't shut up. That's sometimes all you need to get things done. So I was so inspired by being with her. It was Christmas come early to kind of just be in the presence of a living, breathing saint. And I wanted to be able to pass that message on to you all, knowing that it's been a hard couple of years. But if you just get together with a few other parents, your doctor, any other folks to create sort of equity coalitions, start pushing on your school administration, your school board, you'll have a chance of really changing the game. So thank you.
Dr. Rachel Gross is Assistant Professor of Pediatrics and Population Health at NYU School of Medicine and Bellevue Hospital. She's the co-project director of the Starting Early Obesity Prevention Program. And she is also the lead of the NIH Recover Pediatric Observational Cohort Study for Long COVID.
Thank you so much for having me. Hi, everyone. I'm Dr. Rachel Gross, and I am a general pediatrician, and so excited to be here today to share with you about the Recover study. And I really want to thank long COVID families, Megan and Gretchen, for inviting me to come here today. Thank you. So what I'm going to talk about today is, first, I'm going to answer what is Recover. And then I'm going to talk about what we know about long COVID and what Recover is designed to help us find more about. Then I want to share with you a pediatric video that we've developed to really help the community to understand what Recover is, and then to give you more information about what your child or you would do if you joined, and how to help us recruit. So what is Recover? Recover stands for Researching COVID to Enhance Recovery. And it is a research project that aims to learn about the long-term health effects of COVID. And the goal is to better prevent and treat long COVID in the future. In general, Recover is an observational study, which means that researchers collect information from participants. But participants will not get new treatments for long COVID as part of the study. And Recover is funded by the NIH. Really, Recover is a national project, and you can see there are sites all over the country. And we're really aiming to have 40,000 participants as part of Recover, of all ages and races and ethnicities in almost every state. And so research sites across the country will be enrolling adults, children, and their caregivers, as well as pregnant participants and their infants into the study. So as I was saying, the first of the cores is the Clinical Science Core, which is at NYU School of Medicine, to help implement the study across the country, as well as a data research core at Massachusetts General, which is really working to collect lots of different kinds of data and to help do the analyses for the study. There's also a biorepository core, which collects specimens around the country, which is at the Mayo Clinic, as well as a new core coming on board, which is a clinical trial data center at Duke University that will be leading future clinical trials. I wanted to highlight that there are many different components of the RECOVER study. And the one that I'm going to talk about the most today is the RECOVER enrolling cohorts, where we are enrolling these 40,000 participants across the country. But I also wanted to highlight that we're collecting electronic health record data across full health systems, including 60 million records, of which up to 6 million participants have had a history of COVID. In addition, there's many pathobiology studies really looking at mechanisms related to developing symptoms of long COVID, as well as other studies that are collecting different tissues for tissue level studies and clinical trials that will be coming in the future, and that lots of different kinds of data will be collected. I also wanted to highlight that RECOVER is really been developed with a collaborative approach involving stakeholders at many levels, but really central to this has been patients and their caregivers, really working in partnership with researchers, other community partners, federal partners, people in the private sector, as well as clinicians, all collaborating to advance our key scientific aims. And when we bring together the patients and the communities, they're really engaged in many different ways. And so patients and caregivers and the community members are really central to the RECOVER, and their input adds an incredible value. And many of our community partners are involved in many different ways. Representatives are involved in every committee and group throughout the network. And they've been right from the beginning involved in creating study plans and helping to improve them as we adapt our study. And they have access to data and communication through online portals, through social media, through being part of discussions about the patient experience, to having access to a mobile health platform, as well as being able to communicate by email and receive newsletters about what is being updated with the study. So what do we know about long COVID, and how does this inform the questions that we're asking? Well, what we do know, and what all of you know, is that long COVID is real, and it's a growing problem. And that the symptoms and struggles that you and your family members and friends are experiencing is real. But when it comes to long COVID, we know that there are more questions than there are answers. And that is especially in pediatrics and what we know about our children. We also know that long COVID symptoms can be different for everyone, and that symptoms can really change over time. And that there are many symptoms that are more common, and especially in children, such as coughing or feeling short of breath, having body aches, headaches, chest pain, or stomach pain, feeling like you can't think clearly, or having trouble sleeping, or feeling very tired or fatigued, or having changes in your mood. These are just some that are commonly reported by children. But we also know that there's more than 200 different symptoms that people are describing, and this is only growing. And so more is really needed to be able to define what long COVID is for our children. And so this really sparks what are the study questions that the RECOVER Pediatric study is really working hard to be able to answer. First is, how many children are getting long COVID? Why do some children get long COVID and others do not? What symptoms do children feel when they get long COVID? How long do children feel sick and when they get long COVID? And what causes long COVID to happen? And ultimately, we really want to know, how does having long COVID affect children's physical and mental health and their development, especially as they grow? So I wanted to share with you a video that we made about the RECOVER Pediatric study to give you more information about what is involved. So
Hi, thanks for your interest in Recover. By joining the study, you and your child can help us learn about the long-term effects of COVID, whether you or your child had COVID or not. We know you likely have questions. This video will tell you more about Recover and what to expect if you and your child join. Recover is a research study that aims to learn about long COVID. What is long COVID? Long COVID is when a person is sick many months after getting COVID. Symptoms can include trouble breathing, coughing, feeling weak and tired, and problems with memory or focusing. Adults and children can get long COVID, but doctors don't know why. COVID has changed people's lives around the world and has likely affected your life too. By joining Recover, you and your child can help us answer important questions like, why do some children get long COVID and others don't? What symptoms do children feel when they get long COVID, and how long do they feel sick? How does long COVID affect the child's health in the future, including how they develop? So who can join? Babies, children, and adults who have and have not had COVID from all races, ethnicities, and backgrounds across the United States. This helps us learn about long COVID in everyone. Up to 20,000 children and their caregivers will be part of Recover. What will you and your child do if you join? You and your child will be asked to answer survey questions about you and your child's health, use safe at-home kits to get a small amount of blood and spit. You may also be asked to have checkups or other tests. You and your child can skip any question or test you don't want to do. You and your child will not get treatment for long COVID during the study. Most people will be in the study for about 6 months. Some people will be asked to stay in the study for up to 4 years. If you want to join, study staff will tell you more about the study. You'll also get a consent form, which has more details about what you and your child will do if you take part, how much you'll be paid for your time to do surveys, checkups, and tests, possible benefits or good things that may come from being in the study, and possible discomforts or risks of being in the study. Joining the study is voluntary, meaning you choose whether you and your child will join or not. If you join, you can stop being in the study at any time. You and your child's safety and health is important to us. Study staff is here to watch out for you, including to keep your information private. Thanks for watching. We look forward to meeting you and your child and talking with you about Recover. Together, we can learn how to better prevent, test, and treat children with long COVID in the future. For more information, go to recovercovid.org.
So I wanted to highlight who can take part in Recover. Well, as the video shared, we're children and their caregivers, those who have and those who have not had COVID can join the study. And this includes, we're aiming to get about 20,000 children of all ages, from babies, including infants born to mothers who had COVID during their pregnancy, toddlers, preschool age children, school age children, teenagers, and young adults up to age 25 years old. So really newborns through 25 years old. And we're looking for children and caregivers from all races, ethnicities, and backgrounds can join. And this really helps us to learn about long COVID in everyone. And so we're calling for about 20,000 participants across 114 sites to help join to better understand long COVID in children. And so what will my child and I do if we join? Well, overall, the Recover Pediatric study takes place in 3 parts. Part 1 involves all of the 20,000 children and their caregivers that are being enrolled into the study. And this is a one-time assessment that takes place in the first few months of enrollment, where it really involves answering survey questions that can be done at home and giving a small sample of blood or saliva that can also be done at home. Part 2 involves almost 6,000 of the children that are part of part 1 that can be followed up to 4 years in the study. And part 3 will be on a subset of these children who will be invited to do more intensive tests so we can learn more in depth about how long COVID is impacting the child's health. So to give more information, for part 1, which is our initial assessment of the 20,000 children, survey questions can be done remotely, electronically, or with support from sites to answer questions. And there are several examples of questions that we'll be learning about, such as the COVID infection history, learning more about the symptoms that children are experiencing, but really also knowing that COVID affects the whole child. So learning about their global health, other factors such as their diet, activity, sleep, and school, as well as being able to use innovative ways to get samples while children are at home, so they don't have to come into a site for these initial phase. And so these are examples of some booklets that we share with families to help support them collect these things at home. And so the top one is a tasso, which is a pain-free way that attaches to the arm to get just a tiny little bit of blood that can be mailed back to our site, as well as a collection for saliva that can also be mailed back to the site. Then, as part of the part 2, families may be asked to visit the study sites 1 or 2 times each year for up to 4 years. And in addition to be able to continue to do surveys at home, during these on-site visits, there can be simple checkups and exams, which would include getting weight and height, other vital signs such as heart rate, blood pressure, and oxygen, and opportunity to do developmental tests or assessments related to really important aspects of child's health, such as attention, executive function, memory or language, and behavior, and other social emotional well-beings of our children, in addition to doing other tests related to the heart and lungs. And for the third part of our study, where a subset of children will be invited to come 1 or 2 extra times in the study to do more intensive tests, so we can learn more about what's happening in the body and in the mind and the well-being of children with long COVID. And these might include an echocardiogram or an ultrasound or picture of the heart, MRIs of different parts of the body, such as the heart or the brain, exercise testing and other lung tests, as well as other thinking or cognitive tests around child development, which would look at different areas of child development, such as verbal or nonverbal skills, attention, executive function, memory and language, other visual or motor processing or speed, as well as academically related factors related to reading, math, and spelling, and other behavior and social emotional well-being. And so what are the benefits from taking part? Well, by taking part in the study, participants can really help doctors and researchers to better understand the long-term effects of COVID. And this will ultimately help prevent, learn how to test, and treat people or children who have long COVID in the future. Participants will also get these study tests at no cost to them. And what we've heard from many people is that being a part can make participants feel like they're really part of the solution. And we've also heard that many families are worried about privacy and the information that they share. And I wanted to highlight that privacy in this study is very important to Recover. And Recover follows all laws to protect children and families' personal information. And families often ask, will I get paid for being in the study or for my time? And the answer is yes, that we do provide payments for time related to doing surveys or doing any of these tests, and that the study staff at each of the sites can give more information about these payments. And so how can you help? And so the best way is to start to spread the word about the study, which can be done in many ways. You can tell your family and friends and have them consider joining. Send them the website that's listed here to learn more about the study and also to find a site that is near them. We can post on social media. We can leave stacks of Recover brochures in community spaces and such as asking permission to leave it in a library or other place children like to go. And to hang flyers in areas that are important to you. And we have a library of materials that can easily be downloaded and used in your communities. I also wanted to highlight what the website looks like and a way to find out where a site is near you or anyone you know. And so this is a page on the website where you can choose babies, children, and teens looking for sites where they can enroll and enter a zip code to find study sites near them. And you can see sites pop up on the map. And you can see this is an example of a site at Arkansas Children's Research Institute that is enrolling pediatric patients. And these are participants that have had COVID in the past or recently, or even children who've never had COVID. So I want to thank you so much for your time and helping us to better understand long COVID. And I really look forward to talking and taking any questions. So thank you so much.